Hello, everyone. I'm Sherry Rolfing, your host of the ACAP Community Engagement and Redetermination Showcase. These showcases allow you to hear how specific vendor services can improve health outcomes for your members and assist you in optimizing health plan operations. I'd like to welcome you to our session presented by the SIFTWell team. But before I turn it over, I have a few housekeeping items. This session, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. These guidelines can be viewed on our website. We will record today's call and will post it and the slide deck on the Community Engagement and Redetermination Showcase website. Always remember, if your plan is seeking services, be sure to check out our list of preferred vendors just like SIFTWell. Look at the top of our homepage and click on the preferred vendors link. You can also post a note or even an RFP on the Preferred Vendor Connection portal. During today's session, you can ask a question at any time by clicking on the Q&A icon in your Zoom window and typing it in. Now I'll pass it over to Trey to get us started.
Awesome. Thank you, Sherry. My name's Trey Sutton. It's really good to be with all of you. Just by quick background, for those of you that I haven't met, former CEO of a ACAP plan, was on the board of ACAP, on the board of MHPA, and also served as CFO of North Carolina's Medicaid program. So today's call is super important. I often say this that when I think about prisons, I don't think those should be run by for-profit organizations. And when I think about the members that you all serve, I also don't think that those should be cared for by commercial plans. And so for us here at SIFTWell, this is personal, super important, and very near and dear to our mission. Today's conversation is obviously going to be about redetermination. Super excited to be joined by Molly Dean. I've had the chance to work with Molly. She was my old chief of staff at the plan. She's gone on to do super exciting things, and I'll let her introduce herself. So, Molly.
Great. Thanks so much, Trey. Before I joined Trey at the plan, I was in and around state government, Virginia Medicaid specifically, and then was working out of the governor's office at the passage of the Affordable Care Act. And so worked with the likes of Meg and Jenny and Enrique in various roles in helping Virginia at the time stand up the Affordable Care Act and the implementation of that in the state. Have worked with several ACAP plans as well, but I'm now working with state health partners. We work directly with states around Medicaid and other health and human services issues and opportunities. We work with partners like SIFTWell, who are really bringing solutions to bear to support plans, to support states, to support entities that intersect with individuals who are the receiver of services like Medicaid, like children's welfare projects and opportunities. And so really are partnering at this junction around HR1, just working with SIFTWell in the policy implications, ramifications, and how to design the product to work for plans, to understand exactly what it is that states will be held accountable for, and so can really work to solution in a real and meaningful way. So excited about our time here today and ready to jump in, Trey.
Awesome. Thanks for that, Molly. So, everybody, the plan for today is to set up HR1, talk a little bit about the magnitude of HR1, the potential impacts to the plan. Molly's going to take us through kind of a regulatory overview, what this exactly means, some of the really important part pieces. What you'll notice is that when Molly gets into her content, we're not going to go line by line on every slide. You're going to see a lot of content there. The idea is to give you a more comprehensive outline of the things that you should be considering. But again, Molly's just going to touch on the ones that are most poignant or most significant. From there, we'll pivot, talk a little bit about how SIFTWell is thinking about addressing this problem. We'll run a use case that was done for another ACAP plan. In fact, it was featured at the CEO Summit, the last CEO Summit. And then from there, we'll take questions and do a little bit of a review of the actual platform. So if that all sounds good, let's go ahead and dive in. The first thing we want to touch on is just the magnitude of this thing. So what we've done here is pull forward for you some numbers that are representative of the impact when we were talking about redetermination. So as you look on the screen, as a function of redetermination. I believe these are Kaiser Family Foundation numbers. The number of individual disenrolled as a function of the PHE unwinding was roughly 25 million Americans. That most of those disenrollments were actually related to procedural disenrollments. And as we look forward to what's going to happen and how we've looked across our client portfolio, about 85% of which are ACAP plans, we're seeing numbers that could be as high as a 30% reduction in some of those enrollments, depending on plan structure and everything else. So, with that as a setup, Molly, it's obviously going to be a big deal. Why don't you walk us through exactly what it means?
Great. Thanks so much, Trey. So this really is a timeline that sets out some of the key Medicaid-related rulemaking pieces of HR 1. Up until Friday of last week, the red box said we're awaiting Medicaid director guidance for 6-month redeterminations. That's really going to be the focus kind of the HR 1 overview today, is just that new guidance that states received on Friday, orienting you all to that. But really what this highlights is the fact that your state regulators are having to make really important and critical policy decisions, legislative decisions, financing decisions off of best guess information and sub-regulatory guidance. And so there is a lot to accomplish and a lot to put in place to ensure that states are compliant, and therefore you all are capable of participating and working within kind of this whole infrastructure to implement the provisions of HR 1. I think orienting within this slide here really is just December 31 and January 1, just the three key pieces of this that really will require you to pay attention, to engage with your regulators, and as we're here today, just really ensure that you understand your membership, you understand who is possibly going to be impacted, and how you are best suited and situated to support individual members through possible redetermination and then verification of community and work engagement. And so all of this to say we are gearing up, we are moving forward. And then as Trey said, in addition to 6-month redetermination and community engagement and work requirements, you also have the retroactivity coverage window shifting. And so 3 big key pieces here that directly impact your members and your overall membership month to month. Looking at this next slide, really what we have here is information distilled down from the CMS Medicaid Director letter that came out this past Friday. I will say this, you all, by virtue of your affiliation with ACAP, have the most up-to-date information. I was meeting unrelated with some of your leaders last week, and some of the information that you all were made privy to by virtue of your fly-in a couple of weeks ago is thinking from CMS that is not even in public domain yet. A lot of that was really around community engagement and work requirements, how they're thinking about the importance of health plan relationships and flagging, if you will, individuals who likely meet an exemption for work requirements, but it's not anything that's on a standard file, caregiver, for example. And so that's just emphasizing the value of ACAP. But similarly to that guidance, we now have a CMS Medicaid Director letter we've been waiting on around 6-month redetermination. That core requirement, just to anchor us around that, is for the vast majority of all Medicaid expansion eligible members, you're going to have them renew Medicaid eligibility every 6 months. Renewal protections remain. That was clear in the letter. States must first attempt the ex parte renewal, rely on as much of that information that they have in state coffers, if you will, and state systems. Roll that forward first. If automation fails, states must send pre-populated renewal forms. Are states capable of doing this? I don't know, but by January, they're going to have to send pre-populated renewal forms to Medicaid eligible members. They have to be given at least 30 days to respond, and then members retain notice and appeal rights. So these are just some underlying principles that the state CMS Medicaid director letter emphasized last Friday. On the next slide, what we're looking at here is populations impacted by 6-month redeterminations. This has not been clear in a lot of ways. States were interpreting who was to be impacted and who could be excluded very differently. California is on the record one way, Utah is on the record another way. The Medicaid director letter clarified that the only Medicaid expansion individuals exempted from 6-month redeterminations were American Indians and Alaskan Natives. So essentially, all of your Medicaid expansion members will be impacted except the subset of American Indians and Alaskan Natives. There is this individuals enrolled through 1115 waivers. Very few states are impacted by that. Those were leveraged early on by states who were waiting and trying to get Medicaid expansion through. And so they would carve in special services. Virginia is an example of this, created a program for individuals with serious and persistent mental illness and covered them like expansion for a while. Most of those programs have gone away with the broad adoption of Medicaid expansion. So by and large, states with Medicaid expansion, individuals enrolled in Medicaid expansion, with the exception of American Indians and Alaskan Natives, will be impacted. As a result of this, implementation considerations is just the sheer reality for you, particularly as you think about your membership. You will have members who may be exempt from community engagement and work requirements because that's a much more robust list of exemption criteria, but still are going to have to go through the 6-month redetermination cycle. And so it ever more underscores the importance of clear communication, plans, working with your regulators to ensure that messaging is clear, messaging is direct, and that you all are messaging the right messengers, right? Are making the request of members to ensure that they are engaging, that they understand what to do, and that they actually do it, all to avoid coverage loss. This is where it gets a little sticky. Key state policy decisions, states have choice, which means CMS acknowledges that the legislation isn't clear. And so state plans will guide when the 6-month renewal clock begins. So each Medicaid agency, as you all know, has a state plan, which is basically their agreement between the state and the federal government as to how their Medicaid program is going to operate. The majority of states have eligibility on the first day of the month of application. So even if I apply for Medicaid on January the 18th, my coverage, if eligible, will begin on January the 1st, right? Some states, it's the date of application. And so what the Medicaid director letter clarifies is you will just follow your state plan authority in terms of what your renewal clock looks like. But then it's giving state 2 transition options to pick from. The first is accelerate renewal schedules. We were talking about this with Siftwell in the design of what will ultimately be offered to plans. How do we know, when states are going to actually initiate the clock? So your 2 options are this. States can accelerate renewal schedules in 2027 to transition members immediately to 6-month cycles, or they can maintain the existing renewal schedule and just transition members at their next scheduled renewal. How that plays out. So this example was in the Medicaid director letter. I just tried to distill it a little bit. So you have an individual, Max here, enrolled in the expansion group. He has an original 12-month eligibility window from November 1st of 2026 to October of 2027. The state decides that they're going to transition all expansion members to 6-month renewals on January 1st. So Max's eligibility cycle is now shortened from his original 12-month approval to as soon as he hits his 6-month mark. And so Max's new eligibility period is now April 30th, 2027. And so what this does is it allows states to reset groups of individuals as soon as they are hitting a 6-month eligibility mark. This would mean a tremendous amount of people would be eligible at the beginning of January 2027. And so states will begin their renewal process ahead of these renewal dates to get them eligible before the end of their new redetermination period. The second option, with which CMS interestingly signals in the letter that this is probably a pathway that avoids surge, right? So avoiding that overloading of the system, is to really just redetermine and start the 6-month eligibility on your traditional cycle. They use Jane as an example here, who has Medicaid expansion eligibility from August 1st, 26 until July 31st, 27. And so the state would begin outreach, start the ex parte process in May, and give her plenty of time to redetermine eligibility for her originally established July 31st termination day, right? And so they would just start this process, and she would be redetermined again by August. And then she would receive her first 6-month window of coverage approval. So those are the two options that CMS has given states, again, really signaling in the letter that option 2 will likely be more manageable, if you will. Now, you're still going to cycle people through eligibility twice a year, whereas we already struggle in many states with once a year, right? But these are the two options that CMS has given states as of this past Friday. Next slide. And so what this really means, operational implications, states have to determine how far in advance. In that last example with Jane, the state was giving 90 days. CMS is not providing a hard and fast renewal processing time. And so states will have to determine what that is. They just have to have individuals just have to have 30 days to respond to the pre-populated form if they don't clear through ex parte. Also need to determine how to manage households with mixed renewal cycles. So it is very possible that in that, Medicaid auxiliary unit, so people in a household have various renewal timeframes. There is not a provision that allows alignment there. And so how do states want to manage that when you have people in the house having to respond and act and take action at different increments? How to address eligibility transitions between coverage groups. Not necessarily a new thing, but there is significant implication when you think through criteria for exemption and exclusion. An example here would be an individual who is enrolled as part of the Medicaid expansion category of aid and becomes pregnant, and now they're covered as a pregnant individual. Well, now they don't have to go through 6-month redeterminations if they meet criteria, right, to be Medicaid pregnancy. If not, then they will have to go through redetermination, but they won't have to do work and community engagement requirements. So there's just a lot of variables here that states are going to have to figure out and think through to ensure there is no coverage loss just by virtue of chaos and confusion. Another thing that was really clear in the Medicaid director letter is that states are going to have to figure out how to coordinate with other benefit renewals like SNAP. So many states have a multi-benefit application. You can't delay your Medicaid determination waiting on something else for another program. And then lastly, something that states are grappling with is what system updates are needed, what staffing adjustments are needed. Do they need to create state plan amendments because they want to do something differently? And then do they need funding for IT related updates and integration? So all of that is currently happening on the state side. I think lastly, thinking through operational risks, now that we understand a little bit more about Medicaid redetermination, is that 6-month renewals will double eligibility verification events. Like that is just going to have impact on your membership, both your traditional Medicaid members who are just going through their renewal cycles and they are lost in the shuffle because you have really double the amount or twice the amount of expansion coming through at any given time. It is also increasing the likelihood of administrative churn, coverage loss due to confusion or procedural barriers. Back to the very first slide, an overwhelming percentage of coverage loss during the PHE unwinding was because of procedural barriers. And so that is exactly what the SiftWell solution is intended to design, to arm you all with as much information as possible to ensure you know the who within your membership that is likely to be impacted so that you can strategically think through resource allocation to get in front of members, to push information in a way that is meaningful to them, and then to support the right members to ensure that they are getting what they need in hand to meet exemption or to comply and ensure that they know exactly what they need to do in order to retain eligibility if they maintain eligibility. And so with that, we're going to skip this community engagement stuff because it is not new. It is here if you need it and want to rely on it. But I want to give Trey the opportunity to jump in and talk through what SiftWell is bringing to bear. So you can keep going, maybe two more
Perfect.
right there. Yeah.
Awesome. Thanks so much, Molly. And I'm sure there's a ton of questions. We'll make sure that at the end we give you all our email addresses as well. And so if there's more detailed follow-up questions that don't happen in today's chat, that we're available for that. So Molly, I want to take everything that you said and bring it back into something that's a little bit tighter, a little bit more manageable, and informed by exactly what we know today. There's a ton of different trees or leaves off the various branches that Molly talked about. What we're trying to do in this graphic, which was informed by Molly's work, is really break down how you could trace an individual through the decision tree to really prioritize or think about that resource allocation that Molly talked about. So let's start at the top of the house. You've got your total Medicaid membership, and I know there are folks on the line today that have multiple lines of business. Obviously, we're just talking about the implications for Medicaid members. We know there's some spillover on the marketplace side, et cetera. But what we're going to do today is trace the Medicaid line of business, since that's what we're fundamentally talking about. The first branch in that tree is, do we have individuals that are non-expansion or traditional Medicaid versus those that are MedEx, if you will, and that's where the 6-month redetermination requirement comes into play more often. Now, the first carve off is American Indian and Alaskan Natives. There's an entire exemption there, and there is not a 6-month redetermination. That's that light blue box that you're seeing on the top right-hand side. So set those folks aside for a second, and let's continue down the path. The first one is, can we verify an individual's exemption, even though it's required every 6 months? Can we verify an exemption based on either a categorical variable or a verifiable kind of characteristic? And that's that box in the center that's clear. And what you've got there is, again, another reference to American Indian and Alaskan Natives. But then you start going to some of the more categorical ones, or you can think about these almost as Program A categories. Folks that are fosters, Molly mentioned the pregnancy one, incarcerated, already meeting TANF or SNAP requirements. If you fall into one of those, you begin to go left. The other reason that you would go left in this decision tree is through a verifiable element. Things like long-term care or long-term supports and services, fully disabled veterans, caregivers, etc. The difference between these categories is that this is going to require a proactive step on your part to determine that they fall into one of those verifiable categories. And again, if so, then they go to the left, and what you end up with is a work and community engagement exemption met. If not, you're heading towards the right, and that would be full subject to HR1 requirements, including work, education, or community engagement requirements. And then from there, you end up down in kind of a standard outreach or engagement, or a high risk for disenrollment as a function of where you show up. And this is the algorithm that essentially SiftWell is built to prioritize folks. And in those various buckets down below, these are the primary elements that go in, but there's also things like use of pharmacy, lapses in coverage historically. So we've seen these individuals come on and off the rolls over time. And so it's not quite as simple as this diagram, but the major decision points as we work through our plan partners, current enrollment or eligibility, these are the key decision points that we're making. So, all right. Molly, anything to add there?
No, keep.
Okay. All right. So now I'm going to zoom out just a little bit, and I want to talk about how SIFWell does its work generally with plans, and then I want to run a use case. So on the left-hand side, what you all are seeing is some of the information that we get from our plan partners, and then some of the information that we add. The boxes that are highlighted in blue generally indicate the information that comes from our plan partners, and the yellow is the information that we bring to bear. So what you see in the blue box is pretty standard fare. We tend to get claims information, enrollment information, eligibility, and then sometimes use case specific information. The element that I do want to draw your attention to is operational context. SIFWell is not a traditional analytics company because analytics without any sort of connection to what you have the ability to do in the real world is useless. Analytics for analytics' sake is useless. But if instead, as we begin to partner with plans, we get a good understanding of their infrastructure. So, what does a call center look like? Do you have an SMS vendor? Who are your marketing or education partners, et cetera? That's a really important bit of information for us because what we want to do is plug our output back into your infrastructure, if you will, or your operating capacity. Aside from that, though, those yellow ones are what we bring to bear. And those three kind of nodes on that diagram, they represent over 15,000 data elements. And that's everything from psychographic information, demographical information, social related, health related social needs, and then consumer and marketing data. Again, it's about 15,000 data elements. And some of that stuff is actually what like a Samsung or an Apple might use to sell us something. We use to activate people in their re-enrollment journey or in their healthcare journey or in them going for cancer screenings and wellness visits, everything else. So a lot of data that we fuse together and append to every one of your members. The way to really think about us as an applied analytics platform where we segment populations, talk about the best engagement strategies, and then we track that through a campaign part of our platform that I'll show you in just a second. There are a couple different use cases that we work across: general population health and cost. We do a lot of gap closure work. And then lastly, and what we're talking about today is really retention and growth. So as we work through this is what some of our output begins to look like. What you've got on the screen here is groups of individuals that are first measured by likelihood to engage, and then on the horizontal axis, highest risk for avoidable disenrollment. And this is a classic retention case, not a redetermination case, obviously because that hasn't gone live yet. But what I'm showing you on the screen here is actually some real output that we did with another ACAP plan that said, hey, we'd really like to understand where we're experiencing voluntary disenrollments, who are those folks, and what can we do about it in order to retain them? And so what you're seeing here is the output, the first step being kind of machine learning to do predictions. And then what we do is we use a couple different AI techniques, namely explainable AI and causal inference. And so the machine learning gives us the who, the causal inference and the explainable AI gives us the why and the what to do about it. And that's why these groups of people have circles around them. These aren't arbitrary kind of circles that we've drawn around people and said, hey, we've got a zip code over here, we've got a demographic group over here. These groups actually naturally cluster together based on a shared set of reasons or explainable factors as to why they're likely to leave the plan on a go-forward basis. And if you go into one of these, you can actually begin to say, all right, how do I think about these folks and how do I think about the engagement of these individuals? And in this case, one of those bubbles was 913 families with an average disenrollment likelihood of roughly 89%. So almost 90% of those families are likely to disenroll in the next 6 months. In terms of the capitated revenue loss, it's almost $22 million. We've got some information about common access points. And here the motivation is, all right, well, where are these people showing up and how do we begin to connect with these individuals? And you can see the number one access point is pharmacy. And so how do I think about my pharmacy partners as a point of education about re-enrollment, for example, or my emergency departments or my FQs and so on and so forth. So what we're showing here is common access points by which you can leverage those relationships to drive awareness or education, either about filling out forms or about the benefits of their plans, et cetera, et cetera. And then on the right-hand side, there's a lot of more descriptive information about who these individuals are. So we've got a lot of kids in these homes that are using inhalers as an example, so on and so forth. So that's a little bit more about what one of these cohorts looks like. Now, in this next bit, what we're actually showing here is specific strategies, modalities, messaging channels that you could leverage in order to drive higher levels of re-enrollment. So whether it's a personal care manager outreach, SMS campaign, local pharmacies, I touched on that a little bit, but these are very, very specific modalities or channel strategies that you can leverage. And again, tie back to those data sets that I talked about. All right. So a little bit about once you get all that output, how do you use it? Well, the first step is the entry point for all of our clients, which is the Data Explorer. And essentially what the Data Explorer does is it allows you to get your entire arms or your arms around your entire population, see where there's highest likelihood of disenrollment or redetermination risk. And that takes you to the next stop, which is the cohorts. Where are those pockets of really high risk for redetermination loss or general disenrollment, voluntary disenrollment? Who are those cohorts and how can I begin to engage them? And then the last is how do I track those engagement strategies over time? And that's really the campaign and performance tracking section of our website. With regard to the specifics of what we're building in the HR1 space, you can begin to see some of the screens that are going to show up on the redetermination risk dashboard, but I want to highlight a few of them. So one is population sizing and exposure. How big of a problem do you have with regard to the highest risk individuals for not completing their paperwork? Where are there exemptions? Where are there gaps in coverage, and how do we flag those? And then the next one, rolling redetermination timeline. So if you see that graph at the top, that time series one, that actually gives you a sense of by month, how should I begin thinking about my highest risk cohorts for loss of coverage? And, they're kind of shaded in a light blue versus a dark blue. Now, one of the ways that, one of the important reasons that we're giving all our plan partners that information is so that they can coordinate with the agencies that are making those redeterminations. So, all right. The other bullets I just want to highlight here is administrative churn risk, clinical and cost impact overlays. There's also going to be a revenue overlay. So what is my likely loss in capitated revenue? How's my risk pool going to change as a function of all that, all the rest of it? And then lastly, campaign and outlook tracking tools. These are just a few more screens that give you a sense of what it looks like on the campaign side. Left-hand side, it's kind of actual performance against predicted performance, team performance. This one in the center is if there's a series of steps, like we've got to call somebody, we've got to get them their paperwork, so on and so forth. Each one of those steps is represented by a column, and each row in this instance could be one of your care navigators or community engagement members, or even one of the pharmacies. And then lastly, on the right-hand side, this Sankey diagram shows you where people are falling off at each step in that re-enrollment. And again, we're trying to create visibility by way of this information on down to the lowest unit of activation and how do I think about refinement, recalibration, et cetera. So, all right. Molly or Maddie, let me know if I forgot anything there. But the last thing I wanted to do with a little bit more time left is run a few examples of campaigns that were run for other ACAP plans. So we've got one on the retention side, and then we've got one on the growth side. So on the retention side, we had a plan say to us, we're experiencing higher than preferred levels of voluntary disenrollment. We'd like to understand where those individuals are. We'd like to understand what strategies we may employ to drive higher levels of retention for those individuals. Sifwell, what can you tell us? And so we went through all their claims information. We went through call center information. In certain instances, we might use appeals and grievances with the motivation of being, let's identify pockets where the plan is experiencing higher rates of voluntary disenrollment, and let's figure out strategies that we can employ to drive higher levels of retention for those individuals. And what we discovered is that there was a large group of individuals that were likely to disenroll, but if we were able to pump up awareness around certain covered benefits, that we'd likely see a higher level of retention, which the intuition follows. Now, there's an optimization problem, and this plan had it, which is we don't have enough resources to drive awareness around these covered benefits for every one of our members. And what we were able to tell them is this specific group of members are interested in vision and dental benefits. And if you can drive engagement in those vision and dental benefits, you're very likely to see an increase in retained members. And that's exactly what we saw. So they targeted that group, pumped up awareness around the benefits associated with those covered benefits. And we saw a 13% lift in member retention over previous period performance for that group of individuals. And it incidentally was a 14% increase in retained premiums. The other example, again, an ACAP plan said, now this was a marketplace plan to be clear. They said we really want to go after young couples that tend to use preventative care services and tend to stay enrolled for a longer period of time. So who are the individuals that are healthy, use preventative care, and tend to stay enrolled for a long period of time? And so we said, all right, across your entire region, here are the zip codes where there's a lot of marketplace individuals, what your penetration rates are in those local communities or by zip code. And what we basically said is, here are the zip codes, here are the people. Now, this is where it got really interesting. We used some of our supplemental marketing data sets to say, here are the radio stations those folks are listening to. And by the way, they're also very interested in rodeos. And I know that sounds a little bit ridiculous, but it was a rural state and it worked. So they basically launched a series of rodeo themed campaigns. They used a multi-channel strategy, including radios, rodeo sponsorships, and even included a rodeo influencer, and went aggressively using not more dollars, but the same amount of dollars in a reapportioned fashion to go after those individuals to build awareness around their plan and the community connection of their plan, but did so by way of directed channel strategies and a theme around rodeos. And so, we've done a public presentation on this one. It was Mountain Health Co-op. And they said, we're Mountain Health Co-op and this isn't our first rodeo. It was an amazing campaign, and they more than doubled their enrollment in one of their states that they really aggressively went after, which was an in-year $15 million revenue add to premiums. So just a little bit about the power of some of this stuff. This one I've covered on the 13% re-enrollment, and the other just thing I wanted to mention is as they were pumping up awareness around vision and dental benefits, we saw a knock-on effect, and we saw actually a 15% increase in preventative care use, which we were all really excited about because some of those tied back to their quality measures. So, all right, I spoke fast because I thought I had to make up just a little bit of time, but I didn't. So. Sherry, we're well ahead of schedule here, as usual when I get talking. So, Molly, any thoughts?
Yeah, I think just to emphasize why those examples are important, when HR1 passed this past July, and a lot of us were in a bad mood when we were trying to read and understand what it is and how it is going to impact people, we started talking with Siftwell, and it became very evident that even though there was a lot of specificity lacking, they had already done this type of work around their membership retention work with other ACAP plans and other plans in general. Their team is incredibly and wildly capable. And so how do you take what you already have in place and adjust and keep adjusting as we find out more information? But at the end of the day, it's about knowing your members. And more importantly, for Medicaid membership, it's about who are they trusting and who are they listening to? And that is exactly what these insights give plans. It allows them to understand a little deeper who their members are, perhaps what the environmental factors and the influencers are in their life. I think, and the issue that I play out again and again in my mind when I think about the ramifications of HR1 is around pharmacy. It's around the use of all of the inhalers for kids who are living in environmental conditions that necessitate that for everyday living. Um, Obviously, kids likely not impacted here, but young adults, right? And so when you just think about having the power and the information to allow you to partner with the local pharmacy to ensure that perhaps they are part of your messaging campaign, it just really ensures that you all are operating with the best information as possible in order to help and facilitate your membership, not just staying on the plan because it brings you the premium that allows you to care for them, but it also ensures that they have access to the care that they need to live the quality of life. And so, yeah, redetermination every 6 months is new. Work requirements and community engagement is new. Jenny shared with me last week when we talked, just the CMS official explaining that with the community engagement and the work requirement exemption piece, CMS acknowledges that you health plans likely will have information kind of in that verifiable category that Trey was going through on the decision logic. You will have information that the states do not have. And so it is not only a responsibility, but an opportunity for you to help not only make that awareness to the state, but to ensure that the individual has the documentation and whatever the state will require is needed in order to meet that exemption, so that they can check that administrative hurdle off, and continue to move forward with redetermination of eligibility. And so all of that to say information is power. That is not new news, but having the level and the understanding of your membership is critical when needing them to take action. And so that's one of the reasons why we love our partnership with Siftwell, but also with plans and with partners like you all, who are aiming to do good in the world and aiming to care for folks. And so with that, I'll step off of my soapbox, but we'll give it back to Trey, and then we're happy to take questions at this point.
Yeah, and Molly, we got one. So Graham asked, by the way, Graham, great to see your name pop up. Good questions. So the first one is, to what degree is SIFWell planning on doing analysis and generation of frailty and other condition markers as those become clarified across different states, as opposed to using those markers as a feed to the model? Excellent question. We're doing both. So one is we may just be able to inherit some of those frailty markers or other medically exempt markers. And then in certain cases, what we're going to be doing is actually taking the claims information and analyzing where there needs to be advocacy for other exemption categories. And that's why we wanted to start this so early, so that plans can actually begin to take that information back to their states and advocate for those additional categories of individuals that may be less obvious and may not be surface level indicators for medical exemption. So excellent question. The second one that you asked as a follow-up was around related to revenue and expense. Both of those things will be exposed in the platform, Graham. And that's the other thing I wanted to mention, is that if anybody wants to see the initial version of the platform, we're happy to do a live demo. I'm super easy to get a hold of. It's trey@sifwell.ai. Molly's laughing. My email address is maybe easy to get a hold of, but if you send me an email address, I promise somebody will, if not me, somebody will pick it up and we'll get a live demo schedule. And Graham, you'll see exactly in there, we're basically doing taking capitated rates times the number of individuals that fall into the various risk categories, so high, medium, low, and giving folks not only a view on the total for the 12-month predictive period of potential loss of revenue and impact to cost of care, but also on a monthly basis, what do the implications look like on the financial side of the house, so folks can begin to plan not only for the impact to total revenue, but what does that mean for my risk pool, and what does it mean for all the other parts of the financial organization? So excellent questions, Graham.
Yeah.
And again, good to see your name.
The next one I can take, it's besides the state and the plans being invested in getting people renewed, is there a gap in educating providers, community organizations, and other government folks on the challenge of keeping people covered? I think overwhelmingly the answer is yes. There is a challenge because it's confusing, because it's not clear, and because it will change state by state. And so I think that there is also, not to be too much of a social worker here, but there is the opportunity for you all to jam yourself into these conversations sooner rather than later. You understand these people, you understand these communities, you understand these providers in a way that perhaps even your regulators do not, just by virtue of the relationship that you have to have with them. And so I think that there absolutely is a need for conversations to be taking place even now in terms of what states need and want to communicate, who is going to communicate that, and keeping consistency in what is being shared, not only for the message that trickles down to membership, but also in helping providers understand just what is at stake here. I think when you couple redetermination with community engagement with your retroactive eligibility window being collapsed, providers could be left holding the bag. I mean, like, that's just the sheer reality of some of this, particularly when you think through individuals who have perhaps like long duration authorizations in place. They get some type of service routinely. And so they just show up and the service is provided. Well, unfortunately, their coverage lapsed 2 weeks ago and it just wasn't known. And so there absolutely is a gap, I think, in the provider and the community organization space. And I do think that is why it is prudent to think through, and a lot of states are doing this, lessons learned from the from the pandemic unwinding, because we learned a lot from that lesson and from that process that I think really can transfer here.
Molly, we've got another one, and I'm happy to defer to you on. What impact does HR1 have for Medi members? Assuming that's a question about duals, individuals that are both eligible for Medicare and Medicaid. If that's not what the question was, please let me know. But Molly, maybe you can talk to the impact on duals.
Yeah, duals will not be impacted here. So full duals with their traditional coverage would not be impacted by HR1. It is really laser focused on your Medicaid expansion population by and large, as we're talking about redetermination community engagement requirements. HR, like the provision of retroactive redetermination, that would impact everyone. So duals would be impacted there. So that would be a 60-day window instead of a 90-day window of retroactive coverage. But for redetermination and community engagement work requirements, which we focused on today, duals would not be impacted by that.
And if that wasn't the question, please ping back in the Q&A. All right. Just again, I'll put it in the chat, email, and Molly, if you want to do the same, that would be awesome. So folks can, this is going to go to all attendees. I don't know how to do that. Maddie, maybe you can help me get my email address in the chat for everybody. Again, it's just Trey, Trey, at sifwell.ai. We'll get that in the chat.
Yeah, I don't.
Anything else? Oh, sorry, go ahead.
I was gonna say, I don't think there's a way for me to add it into the chat, but we'll follow up with both Trey and Molly's information in an email.
Okay.
Sherry, if you don't mind, we'll send that to you.
Okay.
Yeah, and Terry's posting them now in the chat.
Perfect.
What else can we answer? We got a good one. If if this turns into a cluster, will this only make a better case for those promoting a single payer Medicare for all system? It's a great question. I don't know the answer. Molly's our policy person. I would say that anything that makes this worse and more folks lose coverage I think would serve as a log on that fire. I tend to avoid political conversations. Molly, any thoughts on that one?
We're grateful Trey avoids political conversations publicly.
Yeah.
I think that, and it's interesting, obviously, talking with your ACAP leadership, some of them weeks ago, it's very interesting on the Hill right now. We are hearing that um, those who believe that possibly a cluster is coming with this are saying, don't attempt to put cute little fixes in to help things here or there. Like if it's going to burn, it needs to burn. That is hard for people like us who, by
Yeah.
all means possible, want folks to be okay and want them to have access to their coverage. And if there's anything that's little we can even fix to ease a burden, let's do it. But unfortunately, healthcare is more political today than it's ever been, and so it will be interesting to see. Matt Salo, former NAMD Medicaid executive director, was quoted in an article earlier this week that really just talks about the two perspectives here. You're going to have states who, by all means possible, again, are going to do everything they can to ease the administrative burden, not to just keep everybody on the roll, but to keep those who are eligible in a seamless of approval fashion as possible. Can we ex parte as much of this process as possible, relying on the systems that are already and the information already in place? And can we bring down the threshold of administrative barrier so that people can easily attest to work and community engagement requirements? You are going to have other states who say we need to thin these roles as much as possible. The hit is too great. The system, the money coming out by virtue of all of the tax credits and all of the other financing levers that are being taken away by virtue of HR1. We need to thin this population as much as possible, and by all means possible, they will do that. And so it is unfortunately just a test of, I would say, integrity to some degree. But we will see. It is very possible that this gives fuel to that fire, but only real time will tell.
Yeah. And if you see me at an ACAP conference coming up, I'll buy you a beer and I'll share my thoughts in private. But I feel strongly about what this administration's doing in the Medicaid program. So, all right. Anything else we can answer? If not, super grateful for you all tuning in today. Again, reach out. Doesn't have to be in the context of SIFWA. These could be just general questions. If we can be helpful to you all, we'd love to be. And so feel free to reach out anytime. Again, thanks for everybody for dialing in today. Appreciate you. Appreciate it.
I want to thank Trey and Molly and the entire SIFWA team for this very good discussion. I don't know how to describe it. It's a very upsetting time period for all of us that have worked in Medicaid for a long time.
It is.
So I want to thank you for the presentation and demonstrating how accessing your data can help you help members. As a reminder, today's session has been recorded and will be posted along with the slide deck on the Showcase website. You can find the link under events under ACAP's main page. Thanks for joining us today.
Awesome. Thanks,
Thank you
everybody.
all. Have a great week.
Take care.